we're going to talk a little bit more in depth about the shoulder in brachial plexus birth injuries. And what are we talking about? We're talking about loss of shoulder motion in kids with brachial plexus injuries, which is the more common limitation in kids. And a lot of that comes from tightness around the shoulder as well as loss of active motion. And then what you see often, which is very frustrating for parents, is compensatory scapular winging or the shoulder blade moving around too much. So why is the shoulder a bigger issue than the elbow? Well, there's a lot of things. There's more muscles to coordinate to get movement. There are more nerves that have to recover. There are more places that the nerves can be injured. So you can actually injure some of these nerves in multiple places along the way to the muscle. And there are more complex movements. So there's more range of motion, and that range of motion requires more reliance on muscles for stability. So ligaments that typically stabilize joints in other parts of the body are not as important here because you need to have the ability to turn your stability on and off so that you can have more motion. And that sort of on-off is provided more by muscles than by ligaments. So if you look at the elbow is basically a hinge, and it only has one plane of motion, that's flexion and extension. And so it's a much less complicated system, and it does have ligaments and doesn't require on muscles as much for stability. And what we see with elbow is elbow flexion contractures, which is very common, and less common is radial head dislocation, where part of the elbow joint actually dislocates. So the shoulder is complex, and part of what makes it complex is it's surrounded by a cuff of muscle. You've heard of the rotator cuff, and that's what we mean. It's really just a circle almost of muscle that goes around the shoulder that gives it both movement and stability. And it provides this movement in rotation and nearly 180 degrees of motion in nearly all directions. But it also, as I said, provides stability to the joint, and that's really important. So when we look at the nerves that supply the shoulder, and Aaron did a good job of outlining this, you're looking at the upper trunk, which is C5 and C6, primarily doing the muscles that pull your shoulder out, abduction, and also external rotation. And this is what you see missing in kids with a typical sort of Erb's palsy look. And then there's C7, which is the middle trunk, gives you the muscles that control adduction or bringing the arm down to the body, and internal rotation as well. And that's the rotator cuff in red. So when we look at the Mallet score, which is our way of measuring shoulder function in brachial plexus injury children, you'll see this is abduction. So we look for that, and that's upper trunk function. We look for external rotation, and also external rotation in abduction, which is hand to neck, and external rotation in adduction, which is hand to mouth. For C7 function, or middle trunk function, we're really looking for hand to spine, which is what gives you internal rotation in adduction and also shoulder extension, and also the palm on the belly or internal rotation test, which also tests internal rotation, which is more middle trunk function. So what Aaron was mentioning was this shoulder deformity, or what we call glenohumeral dysplasia, and how this happens. And it is an imbalance of forces. If you look at this, imagine you had a sort of a teeter-totter, and you have it on one side, you have all the muscles that internally rotate, and on the other side, you have all the muscles that externally rotate. The shoulder is naturally more geared towards internal rotation. There are big and multiple muscles. There are 4 muscles that give you internal rotation, and there are only 2 small muscles that give you external rotation. So the shoulder's already precariously placed in favoring internal rotation. When you take out the upper trunk, you take out those 2 external rotators, and you really skew the shoulder into internal rotation. And that's what we see in these kids. And that forces the ball towards the back of the joint. And this is what Aaron was talking about. So Francisco Soldado in Barcelona, and we were a part of this paper as well, looked at, well, is it enough to take out the nerve that goes to the shoulder to give you the kind of contractures that we see? Meaning, does imbalance of the muscles give you the kind of contractures that we're seeing in kids? And the answer is yes, it does. And so when we look at impaired growth, when we looked at it in the animal model, there was another thing that we were missing, which is what Roger Cornwall in Cincinnati and Sia Nicolau in their lab showed us, is that also if you even recover the nerve, it still gives you these contractures at the shoulder. And that has to do with growth of these spindle fibers, which are in the muscle. And you can see they both give you elbow flexion contractures, but also internal rotation contractures. And what they are is these little coils inside the muscle that sense stretch. And as your bones grow, the muscles have to keep up with the bone growth. But if these spindle fibers are not well developed, which they're not in cases of brachial plexus injury, where you take out the nerve, even if you give the nerve back, it still doesn't grow appropriately. And so these muscles don't sense stretch as well, and they don't grow in the same way. And since the rotator cuff is so surrounding the joint, that when these muscles, these denervation of these muscles, or taking out the nerve to these muscles, leads to tightness all around the shoulder. And these give you all kinds of contractures around the shoulder, not just in rotation, but also in abduction, adduction, and in crossbody, or bringing your arm across your body, or bringing your arm out. And what we see is this. It only restricts motion, but it also restricts growth. And this growth restriction leads to joint deformity. And it looks something like this. The Hooter-Volkmann law governs how cartilage grows. And compression, or pushing against the cartilage, actually stops or slows down the growth, whereas pulling on the cartilage or allowing it to be free gives it more room to grow. And so just back to our model where we're now internally rotating and pushing that ball towards the back of the joint and then tightening the rotator cuff, that creates a situation where the back of the joint sees more load than the front of the joint, and therefore the front of the joint begins to grow more. And if that continues without something like Aaron mentioned, which is doing Botox or doing a brace or doing something to keep that ball in the front, then it will deform like this. And this is what we see as early as 3 months of age in kids with plexus injuries. And you can see on the left is a humeral head that's starting to come out of the joint. And you see on the right a normal joint. And my mentors, Mary Beth Izaki and Pete Carter, demonstrated this many years ago now, that as early as 3 months, you can see these kinds of deformities. And so making the diagnosis really can be done clinically to some degree, because oftentimes you'll see that patients lose passive external rotation past neutral, which just means the arm's straight ahead. And MRI, as Aaron mentioned, is the gold standard, but this requires general anesthesia. So most of us now do ultrasound, which has been validated for children up to 1 year of age. And we've done that study as well, comparing ultrasound and MRI. And Peter Waters made this contribution of a classification of deformity. And really what he's talking about is how much ice cream is still left on the cone, right? That's what we're talking about. And so this tightness and deformity of the shoulder, children learn to compensate by moving their shoulder blade a little bit more. And this scapular winging is present in nearly all children that don't recover function by 2 months of age. And even surgery can worsen the scapular winging, because sometimes you take advantage of the increased motion of the shoulder to get actually more function from the child. We looked at this many years ago and found that actually in kids with brachial plexus injuries, their scapula or their shoulder blade moves actually more than in children who don't have a brachial plexus injury. So as Aaron mentioned, the key is preventing glenohumeral dysplasia, and that means passive range of motion, which is really important. And I'm not going to get into the details of that, but that's something that you should discuss with your therapist. And then what we've been going to, in following part of the Helsinki protocol, is external rotation, brace, and splint. Here's a nice picture from Cincinnati Children's, showing you what I consider to be the most important stretch, which is adduction and external rotation. And if you're going to spend the limited amount of time to do this, this is the one you should be doing. As Aaron also mentioned, the super splint, which comes out of Canada, gives you elbow extension, which is nice because it helps to prevent elbow flexion contractures. It gives you supination, which is something that kids are often lacking. And it gives you external rotation of the shoulder. The problem with it is that it's very hard to control external rotation and elbow extension because the same motion gives you supination and external rotation. And how much supination and how much is external rotation, you really can't control an extension. And we've seen in multiple children, supination lead to dislocation of part of the elbow joint, the radial head. So we do not use the super splint anymore. We've gone to the Helsinki teapot brace, which I think is also used by Cincinnati now as well. And Aaron showed you his teapot brace. The one on the left is the Helsinki, and the one on the right is the one that we make. And you can see they're very, very simple. I'm going to skip this because Aaron just covered it. And just to mention on the Botox and casting that we did a study years ago that actually validated Mary Beth Suzaki's paper. But we showed that basically 15% of patients who get Botox will never need any subsequent surgery. That was before we started bracing kids for the long term, and I think our results now are much better. So I'm not going to go into this today for sake of time, but basically there's a lot of procedures that can be done surgically, and we'll cover this on a future webinar that include arthroscopic releases, open releases, all the way down to glenoid osteotomies, which are probably the most controversial. And we have a lot of this information on our littlearms.org website. We will have this recording on that website, and also we'll put it on the HSS website as well. So with that, I will stop sharing. And we'll start taking some questions.